Okay, welcome back to Chapter 16, Respiratory Emergencies, to Lecture number 2. We're going to start with respiratory emergencies. We're going to talk about respiratory emergencies on this particular one. It will cover slides 73 to 103. To treat respiratory compromise, your goal is pretty simple. It's to provide supportive care, administer supplemental oxygen, and provide monitoring and transport of patients that are having respiratory emergencies. The exception is with bronchoconstriction and with a host of bronchodilators available. In respiratory failure, you may even have to intubate and manually ventilate a patient. You may also be using CPAP and BiPAP. They provide effective strategies and may help avoid intubating many of the patients that are in respiratory emergencies. So, obviously, we're going to perform our standard interventions such as oxygen, IV line, psychosocial support, position of comfort, and begin to start looking at all of our diagnostic signs. Decrease work of breathing. Muscles must work much harder during respiratory distress. Patients can compensate for respiratory distress by using substantial energy for breathing to maintain oxygen and carbon dioxide levels. This requires even more oxygen and ventilation. These patients become progressively dehydrated, malnourished, and ultimately fatigued. They will eventually experience decompensation, or what we can term as respiratory failure. To decrease the work of breathing, help the patient sit up, remove any restrictive clothing, do not make the patient walk, relieve any gastric distension, and do not bind the chest or have the patient lie on the unaffected lung. So, administer an effective concentration. Oxygen bag mask ventilation could be necessary with supplemental oxygen or more advanced airway management techniques. They're used in patients who are not breathing adequately. Reassess breathing status and adjust the treatment as needed with these patients. If it's accurate and if the patient's hemoglobin is normal, pulse oximetry is a good guide to oxygenation. Oxygen concentrations higher than 50% should be used only on patients with hypoxia who do not respond to lower concentration administration. Use the 100% oxygen should be for the shortest periods as possible. We do not want to hypersaturate our patients. Most patients with good oxygen saturation, or at least 94%, don't benefit from any supplemental oxygen. Many can benefit from bronchodilators, though. There are varying benefits. Those without bronchospasm will benefit only slightly, and oxygen concentrations may need to be reduced while treating with aerosol sprays. Bronchodilators are ineffective in cases of pneumonia, pulmonary edema, and heart disease. So if any of your patients have any one of those three, don't be throwing bronchodilators on them. That's not their problem. Their bronchioles are intact. Their problem is there's a failure somewhere in the pump or the volume or something along those lines, or the infection. It's not that they need bronchial dilation. Fast-acting bronchodilators, most common types are used, work by stimulating the beta-2 receptors in the lung. They produce almost instant relief. Past strategy was to give aerosolized atropine. Apatrium is now available as an aerosolized or inhaler. The two medications are sometimes prescribed in pre-mixed cocktail, otherwise a Combivent or a Combi Updraft combination. Hint, hint. Popular long-acting bronchodilators include Salmeterol, which is Servavent, and also Cromolyn, which is called Intol or Nasal Crom. All right, so aerosolized therapy. Aerosolized nebulizers deliver as a fine mist a liquid medication. Particles 5 micrometers or smaller enter the lower respiratory tract. They generate optimum particle size. The nebulizer needs a gas flow of at least 6 liters per minute. At home, most aerosolized treatments are run by a small air compressor. The patient may only receive 30% to 40% oxygen via treatment. Aerosols may be contraindicated if removing a patient's non-rebreathing mask creates further hypoxia. Nebulizer can be held in front of the patient's face, called a blow-by technique. It's attached to a mouthpiece, a face mask, or a tracheostomy collar. This is ineffectual if the patient turns his or her head or removes the mouthpiece to answer questions. Whenever you're giving these breathing treatments, make sure that they're taking very deep breaths. There's nothing to discuss during this period. Breathe it in deep. The deeper they suck it in, the more bronchioles get the benefit of the medication. Can disperse other drugs through aerosols such as corticosteroids, anesthetic agents, antitussives, and also mucolytic agents. We can use that stuff. Newer bronchodilators cause less tachycardia as well, rather than the old ones. So therefore, with those kind of medications, you can actually give repeated treatments for bronchospasms if it doesn't work. Here's your meter dose inhalers. These inhalers should deliver the same amount of medication as aerosolized treatments. They do not require additional equipment. They usually the delivery of the method of this method's of a choice when they're at home. Document how often the patient's taking the extra puffs at home, because that's going to give you an idea whether this is working or not. If this one's not working, if you have the same thing on your truck, it's not going to work either, because it's the same medication. So you need to change it to a different type of bronchodilator. To avoid common errors in the patient, the patient should do the following. Like I mentioned earlier, inhale very deeply. Okay, patients should inhale deeply as the inhaler is discharged. Placing the inhaler directly in the mouth often causes medication to land on the pharynx instead of breathing into the lungs. Patients should not blow into the spacer. They need to suck the medication out of the bottom. They inhale deeply, but they hold their breath for a few seconds. Make sure that the inhaler contains the medication that's proper for their use, and that it's full and it's within date. Those kind of things. And then rinse the mouth after a lot of people rinse the mouth after using a corticosteroid inhaler, which that's not going to help because it's being absorbed as well through the mucous membranes. Other faux pas: failure of a metered dose inhaler. Patient must be willing and able to use the metered dose inhaler properly so the medication can reach the lungs. Use of an inhaler is contraindicated if the patient cannot move enough air to draw the medication in deeply into their lungs. Patient may not realize the inhaler may be empty of medication, and then the patient may inhale at the wrong time. Dry powdered inhalers. I hated those things. I didn't use them personally, but I've had a lot of patients that have used them, including my mom. Some respiratory medications, they're a mean of a plastic disc. Okay, the inhaler holds about 1 month's worth of medication, and then a small blister holds each dose. The patient presses the disc to the lips and then inhales deeply to suck out the powder. So some of these medications are delivered in a powder form, and they're just, yeah. Leukotriene modifiers, bronchoconstricting chemicals, are known as leukotrienes. They're released often during allergic reactions. Leukotriene blockers such as Montelcast may be helpful. And then, of course, electrolytes, magnesium may have a role in bronchodilation and severe asthmas. Many protocols are using magnesium in their patients that are asthmatics, and it will turn them around very quickly. Corticosteroids, they reduce bronchial swelling or edema. Steroids. There's a variety of adverse effects that go along with these guys, such as Cushing's syndrome, which is a classic moon face or generalized edema, rapidly changed in blood glucose levels, and also it may blunt the immune system. It is slow discontinuation of this. You don't just remove that off of them. 1 to 2 weeks therapy to avoid long-term use. Don't continue it very, very long periods of time. All right, so inhaled corticosteroids, they do not seem to have the same adverse effects as the oral ones. They've become a standard in asthma and also COPD treatment. Intravenous, these are common in medical emergencies. A single bolus of IV corticosteroids, such as Solumedrol, does not seem to cause any negative long-term effects. We use methylprednisolone and hydrocortisone IV boluses are used for acute asthma. Or acute COPD exacerbations. The onset of the drug usually takes a little bit of time. It takes hours. Make sure that you know what your local protocol is when you're administering steroids. Sequester more fluid in the venous circulation and decrease preload. Treatments for pulmonary edema cause vasodilation. So you're sequestering that fluid in venous circulation, so therefore you're decreasing preload. This works very, very well in our patients that are in heart failure. Nitrates can be used if the patient has adequate blood pressure and does not take phosphodiesterase inhibitors. Morphine sulfate is not likely to increase venous capacity. It does decrease anxiety. All right, so restore fluid balance. It is very common to give a fluid bolus to dehydrated younger patients. Too much fluid, though, in elderly patients or patients with cardiac dysfunction could result in pulmonary edema. So we need to assess breath sounds before and after a fluid administration. Administering diuretics. Giving diuretics to patients with pneumonia or asthma may dehydrate them and cause secretions to plug their smaller airways. So diuretics are used to help reduce blood pressure and maintain fluid balance in patients with heart failure. Diuretics help remove excess fluid from circulation, keeping it out of the lungs of the patients with pulmonary edema. Loop diuretics are commonly used in emergency situations. Thiazide diuretics are often used to treat high blood pressure and heart failure. Many diuretics cause potassium loss, which they really do. They may lead to cardiac dysrhythmias and chronic muscle cramping. Do not give diuretics to patients with pneumonia or dehydration. Patients with renal failure may require large diuretic doses, or they may have no response. If dialysis for renal failure is required, inducing diuresis will likely not be effective. Breathing and support or assist ventilation. Aggressive breathing and support. If the patient becomes fatigued, when they get tired, they're worn out, they're going to stop breathing on you. CPAP and BiPAP may preclude intubation on many patients. So if we can get continuous positive airway pressure on patients that are pulmonary edematous, it may prevent us from having to intubate them, because it's going to push all that fluid back across the membrane and into the circulation system where it belongs. Patients may very simply just require bag mask ventilation for short periods. Gastric distension and vomiting from over-aggressive ventilations can occur with that, so be careful if that's what you're going to do. Continuous positive airway pressure, CPAP. It's used to treat obstructive sleep apnea and respiratory failure. Many people with obstructive sleep apnea wear CPAP units at night to maintain their airway when they sleep. These are applied via nasal pillows, nasal mask, face mask that resembles a bag mask ventilation unit, and a mask that covers the entire face. There's your CPAP premise. CPAP therapy for respiratory failure is delivered through a mask secured to the face with a strapping system. It can be very scary to your patients, but many of these patients that are in these kind of conditions that need CPAP have already gone through it before, and they welcome it. Most of them do. Positive pressure is therefore then created in the chest when the bag mask device is used. The more forcefully the bag is squeezed, the higher the positive pressure. So it's much better to use your CPAP if you can. That constant pulmonary airway pressure is going to help them a lot. All right, so if you are using your BVM, pressure that's too high causes problems. You can create a simple pneumothorax, air leaks that can produce large amounts of subcutaneous air. High intrathoracic pressure can retard or completely block venous return. You need to understand those ramifications that have led to CPR guidelines that emphasize that we use lower ventilation rates, smaller volumes, and lower pressures. We need not to hyperventilate our patients or hyperoxygenate patients. If the patient already has low blood pressure, too much CPAP can stop venous return and cause sudden additional drop in blood pressure. Make sure there's a good seal and minimal leakage. The most common gas in the field is 100% supplemental oxygen. Monitor the gas supply. Pressure relief valve determines the amount of pressure that we're delivering. Some patients may fight or cannot tolerate the CPAP mask, while others can be talked through the process. If a patient is unwilling to use the mask, don't fight it. It will increase the patient's anxiety and cardiac workload and cardiac oxygen consumption. If CPAP works, it can provide dramatic relief and avoid intubation, but if they fight it, you may just have to go ahead and move towards intubation. Bilevel positive airway pressure, BiPAP or BPAP. With BPAP, one level of pressure is delivered on inspiration and a different level if pressure is delivered during exhalation. An example, BiPAP that is set at 20 to 8 gives 20 centimeters of water pressure during inhalation and 8 centimeters of water pressure during exhalation. So it's a nice forceful in, but when you're exhaling, there's a little bit of pressure behind it, so you're not losing all of your expiratory carbon dioxide and oxygen. It gives you a little bit more time to keep it. More like normal breathing and often more comfortable for patients. This is a more complex and expensive device, so it's not really commonly found in the field. Ventilators, love them. Automatic transport ventilators. They're usually flow-restricted oxygen-powered ventilation with built-in timers. They're set to deliver a particular volume of oxygen at a set rate. They're a good substitute for mass ventilation for patients in cardiac or respiratory arrest. They can have basic or advanced features. They're not intended to be used without direct observation. Some are permanently set to deliver only 40 liters per minute of oxygen flow. They're very low for spontaneous breathing, but optimal flow for a patient in cardiac arrest. Intubation can be life-saving, and many can be extubated in a hospital setting with a good outcome. Some issues to consider. Intubation should be the last options for patients with asthma because they're prone to pneumothoraces. Ventilate patients before cardiac arrest occurs. If the patient is in respiratory distress but still conscious, he or she will require sedation and neuromuscular blocking medications before intubating. Patients who are severely intoxicated or who've had a stroke may have little to no gag reflex, so consider intubating them to protect the airway even if the patient has adequate ventilation. With diabetes or overdose, or cases of overdose, an ampule of 50% dextrose or naloxone may change the need for intubation, folks. So make sure we correct any underlying conditions before we go tubing our patients. Inject a beta-adrenergic receptor agonist subcutaneously. If the patient breathing is inadequate, administer methods requiring inhalation may be unreliable or effective. So we may to administer terbutaline or epinephrine sub-Q or intramuscularly. These are not as beta-2 specific, so they may cause more tachycardia or hypertension. Be careful using these in elderly patients because of the additional cardiac stimulation, but occasionally you may have to get a little bit more aggressive with these folks. Instill medication directly through an endotracheal tube. A lot of controversy. We don't really do a whole lot about that. AHA guidelines discourage this practice. IV or interosseous medication administration is preferred. All right, so with that, we're going to go ahead and stop on this particular slide. Give you all another break. We'll be back in just a few minutes to do our last lecture, which will conclude respiratory chapter 16. So let's take a break real quick. See you in a few minutes.